working in public health, community engagement, or healthcare transformation, you've probably heard the term data-driven decision-making. But when it comes to advancing equity, what does that actually look like in practice? In this video, we'll explore a powerful and accessible data tool called the Healthy Places Index, or HPI. With over 18 years in public health, spanning global development in West Africa to Medicaid strategy in California, I've seen firsthand how critical it is to pair the right data with a real community voice. Data can point us in the right direction, but it can't tell the whole story. Hi, I'm Kussy Mackenzie, founder and principal at Pivot First Consulting and Management. I'll walk through a live demonstration of the Healthy Places Index, highlight how community health workforce employers can use it to target their work, and discuss both the utility and limitations of these types of tools. Together, we'll dive into three areas: how HPI can guide the strategic deployment of community health workers' services based on neighborhood level needs, what environmental and social data can reveal about systemic inequities and what it still misses, and why we must ground data interpretation in lived experience, cultural context, and community leadership. At Pivot First, we take this a step further. We use HPI and other environmental data tools to conduct research and shape population health and social impact strategies, helping our clients drive equity-focused investments that reflect the needs of their communities. If you're looking to apply data with both purpose and integrity, this video is for you. Make sure to like and subscribe and share this with others working toward a more equitable health system. Let's get started. Hello and good morning, everyone, to the Community Health Work and Promotor Workforce Capacity Building Collaborative Statewide Seminar 1. This seminar is going to be focused on public tools and resources to define community health work demand.
And I now have the pleasure of introducing Kussy, who, in addition to being a really great boss and a really talented and interesting person in general, I know she didn't pay me extra to say that, she has been working within public health for over 15 years, starting off her career in international development. She served as a liaison and communications officer for several organizations in Liberia, West Africa, with work focusing on reuniting child soldiers with families, refugee livelihood, sexual and reproductive health, and gender-based violence prevention. She has worked as a certified home health aide, as well as owned and operated a home health agency, which primarily served Medicaid clients. She spent nearly a decade at University of California, San Diego. Her work with the university included school-based wellness programming, community clinic linkages, and evaluation research. Before coming to Health Leads in July of 2022, she worked within UC San Diego as a health strategist focused on Medicaid strategy, health policy impact analysis, and organizational change management around transitions of care and addressing racial, ethnic, and linguistic health disparities. She now serves as director of programs at Health Leads with a primary focus on the community health worker and promotor capacity building collaborative. And with that, I'll pass it to Kussy.
Thank you, Fabiola. I thought it'd be kind of weird introducing myself. So today I'm going to be talking about a really powerful tool called the Healthy Places Index. So I'm going to share my screen because I will start off with demoing the tool. So can someone confirm that they can see my screen and the Healthy Places Index website is up?
Yes.
All right, awesome. All right, so the Healthy Places Index is a powerful and evidence-based mapping tool that is free and publicly available. Because community health workers in the promotor workforce primarily serves clients where they live, work, worship, and learn, this tool has value for how the workforce is deployed, the demand for CHWP services within neighborhoods, as well as insight into protective health promoting aspects of communities that are deemed unhealthy. HPI scores are created from multiple indicators, which come from census tract data. I'm just going to do a really brief overview of the site and the tool. So this is the Healthy Places Index page. You can just see very easy site. I would encourage everyone to actually bookmark this website so they can go back and look at their communities. So you click here to get to the tool, which I'll go to in just a minute, but there's an overview of what the Healthy Places Index is. And then down here, which they added, I believe, maybe last year, was a section on Healthy Places Index race and place framing, which is just great information. Without further ado, I'm going to show you the tool. Can everyone see the map of California? Yes? Okay, great. So the Healthy Places Index is a mapping tool. And you can see on the right-hand side here with how to interpret this is with the Healthy Places Index, it gives a score. And visually, the blue, the darker area shows less healthy communities, and the green to darker green shows more healthier communities. And the way the scoring is done is through indicators. So over here, there's a tool section, and there's lots of tools here, but just for today, we're gonna look at these indicators. So you can pull up the indicator, and for the purpose of the demo, I'm going to go into Richmond, California, which is where Health Leads has its California office. Okay, so you can see here as you scroll with your mouse, you're going to see the different percentiles or scores for each of these census tracts. And let me zoom a little bit. So you can see here, for example, this area of Richmond has a score of 19.4, which is on the low side. However, when you're looking, the nice thing about the indicators is that you can look down at the indicators and you can see here, although there's some areas that are not really health promoting, there are areas within the indicators such as neighborhood and clean environment, which actually have high scores. I think there's power behind that of not assuming just because a certain census tract or a community has a low score, that there's not health promoting aspects of that community. That is, so like I said, I would encourage everyone to look at the California Healthy Places Index for their communities because it is a very powerful and useful tool. And also, if we go back to here, just like the labor market information division, there are analysts and other experts that can help you as an individual or your organization with the mapping tool. The other thing really quick is that I think that's really great is that you can download the map of whatever you're looking at. So if I wanted to have this view of Richmond, I just click up here, the download map button, and you get that visual download automatically. So there's many features, but that's not what we're here for today. So I'm going to stop sharing and have Fabiola pull up the presentation. Okay, next slide, please. All right, what I'm going to talk about today is, oh, I'm sorry, can you go back a couple slides? All right, thank you. So the overview that I'm going to cover today, of course, the Healthy Place Index, the tool's relevance to community-based workforce, what the Healthy Places Index data can and cannot convey. I'm going to talk about a case study of crisis response to refugee health around data, and then close out with the importance of having an equity dashboard. Next slide, please. And you can skip this one. All right. So the Healthy Places Index has been a valuable tool for health systems. My previous organization was a large health system that worked with the county to set up COVID-19 testing and vaccine stations and mobile units throughout the county. Integrating the Healthy Places Index data with health records was crucial in testing and vaccine equity work, determining where resources and investments were deployed throughout the height of the pandemic. A large part of my role as a healthcare strategist was providing business intelligence to healthcare leaders. This meant analyzing big data sets, asking critical questions, articulating my findings, and giving data-informed guidance for decision making. Because I knew the Healthy Places Index was a valuable and trusted tool, I got the support of my team's data manager to map the Healthy Places Index to our active patient records. Now, what in the screen is a type of information that can be gathered when you map HPI data to health records. Some things that popped up that we saw was nearly twice as many Medicaid enrollees were in the bottom quintile. When I'm talking about quintile, we broke up the data into 5 sections. So you'll see that in the following slides 1 through 5. When I talk about bottom quintile, that's the least healthy communities. We could be able to tell what percent of patients were in the bottom and top quintile with marital status, the percentage of folks by race, which you'll see later in the graph, the age demographics within quintiles, language, also the utilization of the emergency room. And then you can see their visits to family medicine, primary care, and urgent care specialties were much lower for the bottom quintile than the top, while trauma and emergency medicine encounters were much higher. It's powerful tool even on its own, but when you map it to the actual lives that you're managing, it can be even more powerful. Next slide, please. Okay, so what Healthy Places Index can tell you? What we see in this graph is a distinct trend in primary language and HPI score. The number of Spanish speakers is represented by the orange line, and English speakers by blue bars. As HPI score moves from high to low, primary languages trends change. When we see data like this, we need to test our assumptions and check our biases. Not all Latinx people have Spanish as their primary language, and not all Spanish speakers are Latin. If this were French, we could be talking about Western Europeans or Africans. It will depend on the population and the location you're serving. So who does English speakers represent? The short answer, over 90% of the people on this call. So we can look at the participants on this call and think about the diversity of this group, but we all share English as a primary language. However, when we're looking at indigenous and tribal languages as well as dialects, we may be getting closer to correlations of lived experience and population health of a community. Next slide, please. All right, so what Healthy Places Index cannot tell you. Health equity is linked to racial health equity, and it's charts like these that validate that fact. The natural and usual response is to what statistics are most pronounced. However, this is an opportunity to talk about erasure and how we can use data to prevent and address erasure of social needs of certain groups. Race-based data around disparities often perpetuates the erasure of social needs and health needs of Asian Americans. This is why it's important to ask questions and look at various dimensions of identity and health conditions. Next slide, please. One of these dimensions is language. This chart excludes English and Spanish. The volume of English and Spanish speakers are so high, their inclusion would have obscured and minimized other primary languages, the same way disparities in social needs of Asians get minimized and obscured in race-based disparities data. A few things may jump out to you on this chart. One of them are the orange bars representing the volume and spread of Vietnamese primary language speakers across all HPI categories. Having a focus on race and ethnicity without looking at other dimensions like primary language, you miss the opportunity to wrap our arms around communities that need resources and support. The population health effects of racism and hate crimes are latent. We shouldn't wait for the data to catch up to what we know is coming. The other visual that stands out are the tall blue bars representing Arabic language speakers in the bottom 2 HBI categories, which represents the less healthy communities. There's context to these blue bars that HBI scores or even health records cannot tell us. The Syrian civil war has brought an influx of Syrian refugees to San Diego over the last decade. The population primarily speaks Arabic and are acutely experiencing the housing crisis due to limited availability of housing within Syrian communities in San Diego and predatory behaviors by landlords who are overcharging, overcrowding families in poor standard housing. I say this to emphasize the importance of community-based workforces like community health workers, who will be able to add this type of context and data due to the nature of their work and where they provide care. Next slide, please. On this side, HPI score is represented by color. The dark blue being patients living in the healthiest communities and the light blue representing least healthiest communities. At face value, there may not be anything surprising about the trend between type of insurance coverage and HPI score of patient residents. This collaborative has a particular focus on Medicaid enrollees due to the new Medicaid state plan amendment and payment for community health worker services. If we focus on Medicaid, we see a trend. What I want to call out is that every HPI score is represented among Medicaid enrollees. This matters because it challenges assumptions and personal biases of where we think Medicaid enrollees live. Community health workers are a largely mobile workforce. So when we're thinking about geographic demand for their services, the reality may be that clients will maybe spread out throughout the county. It can be short-sighted and incorrect to assume that deploying CHWP workforce within the light blue, low HBI communities is the only strategy for addressing health disparities among the larger Medicaid population. The numbers have been removed, but some of these bars represent tens of thousands of lives. Next slide, please. All right, so the case study. I want to share a case study of how integral community health workers were in influencing healthcare investment for a nearly invisible group and supporting hospital-based care teams who were in crisis. And invisible in terms of how this group showed up in big data. So to set some background, in 2021, the Biden administration put into effect a humanitarian exemption to Title 42 to allow a number of asylum seekers into the US. There was also a negotiation with Mexico to allow nearly 8,000 asylum seekers in the country per month. San Diego shares a border with Mexico in the Tijuana migrant camp. The policy change resulted in a large volume of women showing up in labor at the hospital. This created a crisis situation within the labor and delivery unit, not only due to the healthcare worker shortage from the pandemic, but also the complexity of the births, the traumatic experiences of the patients, and the language barrier. The language barrier was particularly an issue to caring for Haitian Creole speaking patients. The video and phone interpreter service did not have Haitian Creole speaking staff, and there was a real need for in-person interpreters to be at the bedside. In response, there was one community health worker that would volunteer her free time in the hospital interpreting for Haitian Creole patients and the care teams. She did this for free. She had a job, she had 2 children, but showed up week after week because the need was so great. But her, as well as the care team, were burning out. Then through a county-wide perinatal equity initiative group, a community-based organization spoke out about how their community doulas were documenting experiences of racism and maltreatment of Haitian asylum seekers at multiple hospitals throughout the county, and their concern for the proportion of cesarean sections and the rate of infections at the surgical site. So for folks that don't know, a cesarean section is a common but a major surgery where a baby is removed through a large incision in the abdomen. As a strategist and an advocate for Black maternal child health, I had to convey the urgency behind the request for health system investment in response to the crisis. So HBI score could validate a trend in C-sections among patients living in less healthy communities, which you see there on the left-hand side. But this was not relevant for asylum seekers since they did not have a residence. This was an instance where language data was able to help illustrate the urgency and significance of the situation. I pulled top 3 languages spoken by C-section patients, and Haitian Creole was in the top 3. Haitian Creole would not have shown up in the previous slide with languages because it's spoken by such few number of patients. But because I was responding to what I heard from community health workers, I was asking focused questions of the data, and it gave undisputed evidence of the magnitude of the situation. Next slide, please. So whether responding to crisis or building your business case for investment in social needs services, putting in infrastructure for ongoing organization accountability is absolutely critical. Equity dashboards can serve that purpose. These dashboards are not easy to put together. However, I want to remind folks that data analysts and data managers are some of the most passionate and dedicated anti-racist health equity advocates. We need to lean into our discomfort around data and speak up when we need clarification. There are people willing to help and lend their expertise because oftentimes they are interested in the same questions that we're trying to ask. From a strategy and operations lens, equity dashboards can break down the barriers to accessing necessary and relevant population information instantly. In conclusion, data tools like the Healthy Places Index can bring immense value to how your organization defines demand for community health worker services, but the context and narratives that community health worker workforce will bring to the data is immeasurable. Next slide, please. And that is it for me. So I will open up to questions.
Kussy, you have one question in the chat. Is there a way to upload addresses in bulk and get back each address's HPI score? That would be great for characterizing a patient client population and targeting interventions.
Yeah, most definitely. There's a bulk way to do that. And depending on your organization, if you need support with that, we can request that through the Healthy Places Index.
If anyone else has a question, feel free to raise your hand, and using the reactions feature, it looks like a smiley face at the bottom of your Zoom screen.
Is the HBI tool accessible, and or are there accessible training resources to support utilization by community health or communities? Most definitely. If you go to the website, you'll see on the top portion of the site, there's actually a learning page. They have tutorials, actually really excellent tutorials. So if you want to like self-study and learn about using the tool and build that skill, they have that available. This is really widely used throughout California. So as for an organization, it's powerful, but also as a community health worker, I think this could be a great skill to have with how to interpret demand for your services and help with service level demand.
You have another question from John. Many programs use Cal and Veto Screen as a track-based indicator of similar factors. Are there reasons to use one over the other?
John, I'm not familiar with that platform. I would just say the value of the Healthy Places Index is because it is so widely used, especially by large health systems. I think that's important because there's some folks have goals around the integration of community health workers and put them authorities into care teams and with hospital and clinic systems. And I think there's value there with being able to speak the same language. If you say HPI, then a lot of folks are going to know what you're talking about. But short answer is I don't know the reason to put one or the other because I'm not as familiar with that platform that you mentioned. All right, so for the next steps, the regions are going to receive technical assistance on labor market information and service demand for their county. So we're going to help facilitate for the collaboratives that want the technical assistance. We will support you in connecting you to your consultant for your county with LMI. Like I said, regions are going to facilitate community health work and implementary convenings over the next couple months. And the region is going to report their learnings and plan tactics for financing regional goals around workforce development. And then we're going to be reaching out about the new SharePoint collaborative dashboard that's going to help support cross-regional engagement. And so you'll be hearing from us soon. right. So with that said, we'll give folks another minute to finish the poll. And then Leandra, can you please drop the last question in the chat?
Yes, I put the question in the chat. It said, what action will you take from today's seminar? Katie already posted a wonderful answer. We are part of a practice grant and working on CHW's onto care team at CPCMG and are starting to see contracts for CHW services coming out from the MCOs. So that's great news, Katie. Thanks for sharing that. Kevin says we use multiple tools, including the HPI, also using the vulnerable populations footprint by the community, and it's also free for public use, he says.
Excellent. And I know we're over time, so if you need to drop off, please do. If you're in the middle of your evaluation, please continue to do that because we need the data. Let's keep it real. Thank you so much. Thank you, Rosendo. A huge thank you to Javier and Annabella, our interpreters, for helping making this a more inclusive presentation and create an experience for everyone. And thank you to the team, the support team, especially Brianna Kennedy, doing us a solid for the past 2 weeks. Incredible. So thank you.